We're going to go ahead and get into our presentation today. I know everybody sees these around everywhere, but we always want to stay safe. And in the laboratory, I know that everybody's main focus is patient care. Whether you're trying to just go in and get a paycheck, at the heart of every laboratory, we want our patients to get the best patient care. Let's all have that at the heart of our practice. And what we want to do today, and our objectives are to really discover your role in the histology safe practices. I'm going to give you a couple tools to improve your current practices, and if I hit on a couple things that really hit home with you today, I have been a success. I want to decipher the unique areas where safe practice may be improved. Someone once said, the greatest room in the world is room for improvement, and I really truly believe that. No matter how great and how far we've come, there's always room for improvement. We also want to realize the benefits to patient care by improving current practices. While we're in the laboratory and we don't see patients day to day, their samples are in our hands and their treatment is in our hands. So we really want to realize the benefits to patient care by improving current practices. And we want to take practical steps to improving your laboratory. We don't want to go so far to slow down our current practices, but we want to take those practical steps to improve the laboratory. What is change management? When we look at change management, what is the heart of change management? So here is a nice little quote by George Bernard Shaw. Progress is impossible without change, and those who cannot change their minds cannot change anything. At the heart of change is changing our minds. And why do we need to change our minds? Well, if we are in the laboratory and we think that everything is as it should be, we can't really advance to the next step. And when we advance to the next step and think, you know, what is out there and what is possible, then we're really able to improve not only our practices, but our laboratory and morale, and in the end, patient care and our relations with our consultants or doctors, and in the end, just the overall picture of what our laboratory can be. So that in the end is really what I'm trying to get at today. And am I the end-all expert in this? Absolutely not. Like many others, there's so much more room for me to improve in my practices day to day, not only in the laboratory, but in my relations with others and many other areas. So I am just here as just an avenue to help others, and I'm here to also just be a student as well. So let's all work together to, you know, maybe change our minds little by little, or maybe even take great steps if it's necessary. But let's also just have that avenue of learning and the mindset to be able to change our minds. Okay, some of you might be familiar with the ADKAR model, and for those of you who aren't, it's just the steps you take to be able to change. And so the first one is really the awareness. And the key questions around awareness is, do I understand why we need to change? A little later, we're going to talk about a patient who was affected by this change. But right now, we need to understand the impacts of the change and why it affects me as well as the patients. And do I understand the consequences if we do not change? And who can I go to with my questions? The second one is desire to participate and support the change. There are those in the laboratory who do not want to change, and there are also those who are going to be on the forefront of change. How do we balance those who do not want to change with those who are just on the forefront of change, and blend those together to be able to go to the next and the knowledge? And today I want to talk about that knowledge. And the knowledge is really what we need to talk about, because that's usually the barrier. Most people want to improve. They want to make the laboratory better, but where we lack is this knowledge. So, and then after that, we have the ability to implement the required skills and behavior, and then the reinforcement to sustain the change. So again, this awareness and the need to change is the most common barrier, the most typical reason for resistance if this is not present. So achievement of awareness is marked by understanding. We need to understand the nature of the change and why it is needed, and risk for not changing. So in this knowledge, we need to know what we can do to help others gain the confidence they will need to be successful. Helping those around you is very important. While you might be one who is on the forefront of this change or on the opposite side, one who is not wanting to change, we need to be able to work together to achieve change and to understand the change, and also to teach others to apply their current skills to a new expectation. These are the top 6 areas that I'm going to talk about. You can see that any of these areas have a possibility for the specimen to have errors, and I can say that me personally, working in this field for about 14 years, have seen specimen mis-ID at any one of these areas. I'm going to talk a little later about possibility for changes as well as possibility for errors. The first one is specimen receipt. When you take in a specimen, where is the possibility to reduce these areas? Specimen grossing, embedding, microtomy, distribution, and also posters. I wanted to give an example of the first laboratory that I worked in. It was a small laboratory in southwestern New Mexico, and I was just coming right out of school. I was eager and willing to basically do anything in the laboratory. There was only 2 techs in this laboratory working directly with the consultants, or physicians, if you will, and I was just eager and willing to do everything. In this laboratory, there was very little technology. We did all the immunostains, all the special stains by hand. We went into the surgical suites. We gathered the samples by ourselves. We wrote on all the cassettes. We did everything as fast as we could to get everything out, and there really wasn't a focus on quality. Well, I don't want to say quality, a focus on ensuring that everything was as accurate as possible, and anything that was done wrong was a direct implication on the tech. It wasn't about the process. And again, I want to emphasize that it's not always the person's fault. We need to go back to, if you continue to do the same thing over and over again, you're going to end up with the same results. We need to focus on the processes behind the errors. When I gathered samples, we would take the sample directly from the surgical suite, go accession it as quickly as possible, and write on the blocks and get it to the I'm sorry, we say consultants here at Mayo Clinic. Previously, we'd say pathologist. So we'd get it to the pathologist. And one day we were bogged down, as with sample after sample after sample, and I was the only histotech available. So I'd accession a case, put it up, get it to the pathologist, get another case, and we had 2 breasts back to back. And you're very familiar with breasts or very large samples, and I unfortunately gave both breasts the same number, and the doctor put both breasts in the cassettes without verifying that they matched up with the sample. It came back on me, and I was the one that was in error. The doctor didn't take responsibility. It was all my error, and I broke down. I thought it was all my fault, that I should have done something different. And you know what? I could have done some things differently, but also we need to talk about the process. So let's go down to the next slide. This is a woman that a similar thing happened to her. This is an Halifax area woman, had an unnecessary mastectomy after his test results were swapped in 2013. This woman, Sharon Fisher, was told she had breast cancer and opted for a double mastectomy. A few months later, she was informed that her specimen was mixed up with another sample. They admitted that the tissue samples were switched before pathology analysis. So Capitol Health chose to implement a new computer barcoding system to improve processes. And they're very excited about this barcoding system. But let's talk about the processes in place that could prevent this. Thinking back to my situation, was I young? Yes. Was I eager? Yes. But what else could have prevented this? In my case, it happened at specimen receipt. One thing that we suggest here is not having 2 similar cases back to back. And I know that several different institutions do this as well, whereas others cannot do this because they're only taking in certain cases. So if you are a GI specialty case or a specialty hospital, you're only receiving GIs. You cannot have, say, a GI case followed by a breast case, followed by a biopsy, a Durham excision, or something like that. you would only be able to have GI cases. However, in a generalized hospital, you could practice this approach. Therefore, if for some reason the blocks were mixed up, the consultant or pathologist could easily determine which case belongs with which. The other thing that we choose to do here at Mayo Clinic is have a procedural pause at the window of the surgical suite. At this point, the nurse who brings the sample stops and verifies the tissue that is being received, the name and the date of birth, to ensure that all the information is present, that they don't have to go and verify anything, to say that this is the left breast versus the right breast, or, the left iliac crest versus the right iliac crest, just to make sure that the material that we're receiving in surgical pathology is in fact correct. The other thing that we can do to make sure that the material that we are receiving, say, in histology versus surgical pathology is correct is taking pictures or barcoding the material in a certain LIS system. So for example, here at Mayo Clinic, we have 2 campuses here in Arizona. We have one campus in Phoenix and another campus in Scottsdale. So we take pictures of the blocks that are sent from our Phoenix campus to our Scottsdale campus. So if for any reason there is a question of what has been sent and what has been received, we can go and verify those questions. We also want to confirm all mandatory information. CAP requires that you have 2 IDs at all times. One thing that you need to keep in mind is any barcode is also considered a source of identification. We have more than just the barcode. We ensure that we have the patient name and case ID on everything, but we also can use medical record number. You can use date of birth. You can use any other information as a source of identification. Another possible reason for the woman getting a mis-ID is not holding a case when you do not have this mandatory information. We all know that sometimes consultants or pathologists rush cases through because they feel like they need to get the cases. Either they need to go and have something done, they need to get out early that day, or something else like that. Sometimes it's worth slowing down and keeping a case until all necessary information is obtained. Other things that we receive here at Mayo Clinic are consult cases. These are cases that have previously been accessioned, processed, cut, so they're either blocks or slides that have been received and processed in another institution and then sent here to Mayo Clinic for a consult. Those cases are often set aside until they receive all the necessary information. And these are not only for billing purposes, but just to verify that we have the correct patient. It is important that we receive all this information. And while the consultants, again, or pathologists often rush these cases, it's important that we receive all that information to verify that it is the correct patient so that information can go back to the right doctor. Another thing that we do here at Mayo Clinic is just-in-time printing. Some of you might be familiar with this. And again, going back to my case where I mixed up the samples, I had to write on every cassette. While that is a very dated process, now all cassettes can be printed from a machine with the patient information, either the name, the accession number, date of birth, whatever patient ID you choose to put on it. They also can have a barcode. You can see here in the picture that this barcode is not only on the cassette, but also on the specimen. Just-in-time printing allows for that specimen, once accessioned, to be scanned at the grossing station. And at that time, the cassettes then come out. So this really helps because there are no backup of cassettes. Cassettes are not just sitting around waiting for the grosser to gross that specimen. It's a very lean process. It allows the grosser to add additional blocks and not having additional blocks just sitting around if they do not use them. In the LIS, we recommend putting the minimum number of blocks associated with that case and then just adding additional blocks, because it's often very difficult to remove blocks in that system. So it's a very lean and nice process. We also, this is nice because you verify that the material has been grossed at this time, and then it is then transferring to the next step. The next step in the process is embedding. Actually, so let's take a step back. So after grossing, you go to the processor. And while I don't have a slide on this, there can be additional marking steps during the processing step. Here at Mayo, we choose not to scan going from the grossing to the processing. And the real easy and simple reason we don't do this is because we don't want to expose our lab aids, if you will, to the formalin between those two steps, because after the grossing step, they have to remain in formalin before they go into the processors. But you can also track which processor they go into. You're very familiar that there are different types of processing. There is formalin fixation processing, there is microwave processing. If you track either by hand or with scanning, or just in spreadsheets which processor they go into, you can then determine if there are any quality issues on the backside, what might be the root cause of that issue. Right now we have chosen not to continue that process because we have gone entirely to formalin fixation processing for all our large specimens. Our small specimens do go through the quick microwave processing, so we know exactly which specimens go through which processing. So it's a pretty standardized step. But you can choose to do that if you have more of a random assortment of cases. Here at embedding, the other thing you can choose to do is verify patient information through barcoding. You can see here, this is, again, we don't want to endorse any type of company, but through barcoding, which can be any specific vendor, you can scan the case at embedding, which can then pull up that patient information, again, the patient name, medical record number, date of birth, session number, or any other patient ID can be pulled up to verify that it is that case. The other thing that can be pulled up is a confirmation of tissue pieces, as well as the type of tissue. This can help because it allows the technician who is embedding to know how to embed that tissue. For instance, derm pieces need to be embedded on edge, and breast tissue or anything that is larger just needs to be placed into the cassette. At this point, you can also document issues. For instance, if this case needs to be decaled, or if it has insufficient tissue, or for some reason the block has opened during processing, it is important to document these issues at this step. This is probably where most histotechnicians spend most of their time. This is actually a picture of our laboratory. You can see that we've tried to lean our lab as much as possible. Like many laboratories, we don't have much space. You think that Mayo, we have a little bit more money, but space is a commodity. The only way we probably get to have more space is if we stack our technicians on top of each other. But what we try to do is standardize our workspace. You can see here that we try to have buckets that have color coding. In these color coding buckets, we try to place the same type of supplies in each bucket, and we replenish those buckets daily so that there is a very lean workflow. We have everything supplied every morning so that there is no need to get up and sit back down. We have all of the slides available at the workspace. And we need to have a dedicated rework area. Rework is usually the most likely place for error. So in each space, we allow the technician to dedicate the rework area. And what is rework area, you may say? So rework area is, for instance, if you go to, so all the blocks are faced, and they're soaking, and they're waiting to be cut. Once you cut a block, if for some reason the tissue chunked out, if it is dry, if any type of issue occurs, you then set that block off to the side to soak longer, to have surface decal, anything else like that, that then needs to be set in a certain area for rework. The other thing we try to do with our current barcoding system is to not leave any labeled slides out to be grabbed and then have tissue placed on that slide. So that slide is then thrown away until we just have to reprint the label. Previously, when all of our slides were pre-printed, this was much more of an issue until we went into this barcoding system. Barcoding is drastically improved any of our mis-IDs. However, we have found that we've had a couple. So we try to go and back and work with the technician, not necessarily to place blame if there is a mis-ID, but really to rework the steps and determine why this occurred to prevent this from happening again. Again, it's important to learn the process, not to place blame. And the next area is distribution. While I don't have a picture of this, it's a very tight space. We want to keep this a very lean process. Distribution is probably one of the most difficult areas to work in. We do have a lab aide doing this process. It's after the slide is cut, stained, and we are distributing it out to our consultants. All of the cases then are placed onto a slide, which I know you all are well aware of. We then go back into the system and assign it to a pathologist. We have to also place all the immunostains and ancillary tests with that. We need to also do another process that we do here that we found that's very beneficial. We call it our slide block check. We match our slide to our block, and we actually physically take our block and match the slide on top of it. This checks for orientation. We have a certain orientation that we like to keep all specimens based on tissue type. This also checks for macroscopic quality. We need to make sure that the tissue is spaced in appropriately. We also need to make sure that we have all of the marked edges and that the tissue is not tattered or any other possible challenges. We then have what we call a Pareto chart that we mark any issues that we may see, and then we take that specimen back to the original histologist to recut the specimen. While you may say, wow, that would be very frustrating if I got the case back, we have found that if the histotech knows what their issues are, they're able to improve on their processes and reduce rework. That's one thing that we find, that if we're able to improve processes and reduce rework, we're then able to improve throughput. And everybody is happier when we don't have to rework any cases. We also perform a microscopic review of approximately 15 to 20% of our cases. This is performed by managers, supervisors, and leads of the department. Periodically throughout the morning, the cases are pulled and taken over to the microscope. We then, with education, we know what each tissue type should look like, what the cellular elements should look like, and we verify on what we call our blue sheets, lovingly. They then have a check mark for acceptable, adequate, and unacceptable. And once we check those boxes, they are then compared to what the consultant, again, or pathologist states that these cases are. So we compare the two. This also fulfills our CAP requirement for microscopic review. Each morning we also review an H&E slide for each of our runs for the H&E stainer, just to verify that the stain run is acceptable. Sometimes it's off, and sometimes slides have actually gone through before they review that slide, and it's frustrating, but as long as we can review those and get those taken care of in time, there is no rework. And again, no histologist knows frustration more than having to recut cases, especially those frustrating cases like bone or breast. And then we have our post orders. Some immunostains and special stains are ordered up front. Others are ordered on the back side. Again, like I told you, with my first job right out of college, I performed all immunostains and special stains by hand with a timer and marking a little line around each slide. I performed all these stains, and And while it was frustrating, I think I learned a lot. But you need to, while understanding that made me a better technician, I think with automation, it's come a long way, but repeating any ancillary puts us at increased risk for losing patient tissue. So we definitely do not want to do that. So with each post order, we really like to verify that we have that order, and we need to, with each slide quality, we need to make sure that that quality is sufficient before we send it back to the pathologist. We also like to verify when each new lot has come in. So each new lot for an immunostain, for a special stain, we have a full sheet that we sign off. Now that we're going into PathDX, as he stated earlier, that I am overseeing the project here for Mayo, Arizona. We're going to be going into TQC where that's computerized, and we'll be able to sign off on it electronically. But right now we're using a paper sign-off sheet, and that's also signed off by our consultant. All of our positive controls are also reviewed by a certified technician for every case. I know in different institutions they batch different immunostains, special stains, and the like. However, here we do put one control per slide. We found that that helps us to troubleshoot if there are issues. We've really come a long way with these issues, and the quality of our immunostains and special stains is very superb. I do say that because I used to be in charge of special stains and immunostains. There are a couple cases where they do batch their special stains and immunostains, but those are few and far between. And any questionable lots or tests are pulled for further testing. They're kind of quarantined over in an area for further testing. If for some reason that test has been pulled for an extended period of time, we send all those tests up to our sister institution, Mayo Rochester. However, that does affect turnaround time, so we try to get those taken care of and turned around as quickly as possible. Very quickly, I think I've gone through a couple things that we do to try to assure quality. Again, I want to tell everyone that we by no means are the end-all, be-all quality gurus. I think that every laboratory really has room to improve, and we really strive to improve all the time. There's always room for improvement, and with every year and with every meeting that I go to, I find new ways to improve. With our new PathDX, like I said, going to a computer-based TQC system, we'll be able to find ways to improve. With CAP and their guidelines, there's always something new coming out. So now this kind of takes us to our desire. I find the ability to improve our laboratory a driving force for me to get into the laboratory and to assist. The other thing that I find a driving force is teaching others new ways and inventive ways to improve the laboratory. I think that right now, I hope that I've instilled in you a willingness to support change. Personal choices influenced by the nature of change. It's really a personal choice to support the colleagues around you. If you see that they're doing something that's not safe either to their personal safety or to the safety of the patient, please reach out, and obviously a respectful and a loving nature, and and let them know, I see that you're doing this, but would you consider doing this other option for the safety of our patient as well as your personal safety? Just think back to where we were 30 years ago, where people were smoking and eating and drinking, chewing gum, adjusting their contact lenses in the laboratory. We don't want to go backwards. We always want to strive to get better, to get safer, to just be more proficient in the laboratory. We always want to make sure our personal situation is safe and that our patients are really safe. And we want to have intrinsic motivators, because improving personally, professionally, spiritually, it's always important to always have those motivators and improve every day. So I hope that I've given you a little bit of knowledge on how to change. This education-based training towards expected behaviors, I don't want to think that I expect you to change. I hope that I've given you, as well as maybe some of your supervisors, a little bit of a tool on on how, you can change, and maybe you're already doing all these things. And to that I say, congratulations, that's great. Maybe you can share with me some of the wonderful things you're doing within your laboratory. Again, I want you to know that this is just a network. As histotechs and as laboratorians, we just should work together to make it a safe and wonderful atmosphere for us to work together and for our patients and our clinicians. We also want to give the details on how to use new processes. There's always new processes on making the laboratory a lean and safe institution. We want to use systems and tools to always get better and understand new roles and responsibilities to affect your laboratory, because you are important. You are every day working toward diagnosing the patient. I saw a wonderful thing that said, without the laboratory, doctors are just guessing. And whether it's blood work or tissue samples or cytology samples, the laboratory is very important. Without us, there would be no final diagnosis. So I just commend you for your work in the laboratory and for your continued efforts toward making it a safer place. So again, this is just a knowledge network. I ask you to come to me with any questions that you may have. Here's my email. Feel free to reach out to me anytime.